Very glad to be here. It's kind of a cabaret environment. It's very nice. I'd like to talk about this particular subject because it's critical to addressing how we actually mobilize the vast resource of a health science center to measurably improve the health of the state. And it's not easy to do. A lot of us talk about it, but we're just kind of taking those initial steps. And I'd be very interested in your feedback. Yes? This is not... This is just for web streaming. Yeah. Should I talk louder? Yeah. Louder. Ah, okay. I got my water ready. Like any innovation, we have to talk about how the innovation relates to the needs of the state. And New Mexico is about the second or third poorest state in the country. Most of its counties, 30 out of the 33, are health profession shortage areas. And it's a border state, so it has issues of in-migration, of undocumented workers that are very important for the economy of the state, though there's stress on the economics of the health system. We have a major problem of maldistribution of our graduates by specialty and geography. And what I'll show you later is how there's a misalignment between the research priorities of the Health Science Center and the health needs of the state. As in many parts of the country, we have a looming workforce crisis with a desperate need to increase primary care, and decrease resource. The biggest problem we have for primary care is a lack of internists. It has almost disappeared as a primary care specialty in what used to be the largest primary care specialty. We have a problem with decreasing, nationally, with decreasing ethnic underserved minorities, and that has implications in access to care. Our workforce in nursing is a growing disaster, with a very aging nursing workforce. And if I were to go around rural New Mexico, what I would see is even more important than primary care access is dental and mental health. Those are the two huge areas besides primary care. You know, if you look nationally, the numbers of ethnic minorities, percentages coming into medical schools is pretty flat. A little bit higher in some, a little bit lower in others, but it's really not taken off as we had hoped. Yet the population by 2050 is going to be, the majority will be ethnic minority. In New Mexico, currently the majority is ethnic minority. So we have about 45% Hispanic, 10% Native American, 2% African American in the state. So we have to figure out a way to make sure the workforce addresses that. The other thing that's happening, which people don't talk about, is that the income of the families of physicians coming into medical school is going up, up, up. So between ethnicity, socioeconomic background, the disparity between who the doctors are and who their patients are is getting wider and wider. This is just a slide from a study showing that if you're a Hispanic physician or a Native American, African American physician, your likelihood of seeing patients of that ethnicity is astoundingly higher. So that you can see this issue of disparity between what people need and what we're producing. The thing we're trying to tackle in New Mexico is, can we actually mobilize resources to address all these social determinants, those things that cause disparities? And if you look at the what's causing ill health, the underlying causes, social factors, behaviors, about 80%. We focus on health care. 15% is important, but it's not the major intervention we need. Why is that? Well, one of the problems is we're not paid for what people actually need. We get paid for those things of higher and higher income, which tend to be more and more procedures and higher tertiary, secondary care facilities. We're not paid as much for upstream interventions, which would be more public health, my colleague. And one of the dilemmas is, if you look at any Department of Health in the United States, it is so badly funded, it's so categorical, their impact is diminished. So there needs to be a way in which the much better funded curative healthcare system can partner with public health to have some kind of an impact. Barbara Starfield from Johns Hopkins did an analysis of why it is that the United States health system, ranked by WHO, is 37th in the world. We're the lowest of all the OECD countries, of all the Western countries. She came up with 3 factors. We have a terrible primary care system. It's almost non-existent as a system. We have very, very high socioeconomic disparities, and we have an inappropriate use of technology such that currently they're ranking, and it's actually an underestimation, iatrogenic morbidity and mortality is probably the 8th leading cause of death in the United States. And in fact, if you had an adequate primary care system, you could ameliorate some of the negative effects of high-income social disparities. If you look at New Mexico, years of productive life lost, which essentially is premature death. Our leading cause are injuries, most of that road accidents and that are alcohol related. Second is smoking, with cancer, with smoking as a major cause. Third is homicide and suicide. And if you look at how we're prepared as physicians and nurses, what our training proportions are, this in no way reflects how we're trained. So there's a discordant, we're not attracted to dealing with these kinds of interventions. But that's what our society is suffering from and needs us to do. This is a very good example of how we emphasize quality and how we're measured in quality in healthcare and how disparate it is from what actually happens in communities. And this is the Native American population in New Mexico. It has by far the best quality of care for diabetes. You'll see in that population highest rates of screening for eye, feet checks, hemoglobin A1Cs, the highest. They also have the highest mortality from diabetes. Why? Because the measures are all of what we do in a clinic. It doesn't touch on the horrendous socioeconomic disparities and problems Native Americans face on the reservations and in urban areas. So again, this is the perfect example. We cannot look at quality only of what happens inside the 4 walls in the clinic. And that's one of the dilemmas with a patient-centered medical home. It's terrific. It's much better than what we have, but it's not enough. To add to our misery in New Mexico, we look at a lot of things, but this is one of them. It's the social health in the 50 states, and it looks at child poverty, teen drug use, unemployment, suicide, all of the social and medical problems that we face. And New Mexico, unfortunately, ranks at the bottom of all of these factors. There's a study that was done by Felitti, and this is now actually a component of CDC. They have a whole unit that's studying this. And what he found, he was the head of preventive medicine at, he just recently retired, at Kaiser in San Diego. And he did tens of thousands of questionnaires. There are 400, I look at this, like 400 questionnaires, just trying to see what the risks were so that they could make interventions when people enrolled in this accountable care organization. And he found something very surprising, that when he looked at some of the history of childhood environment, he found that if you looked at these 7 factors that were, he called them adverse childhood environment, which was if as a child you were physically, sexually, or emotionally abused, if someone in your family was in prison, had a mental health problem, had alcohol or substance abuse, or your mother was beaten, as you added up those factors, your chance of every single chronic disease as an adult rose. So he could correlate, again, these social, economic environment issues with adult chronic disease. And what he found by careful interviewing is that one of the links was that you tended to seek comforting behaviors very quickly when you're in that kind of a stressed environment, where you have high chronic stress. It's not unlike Marmot's data from England, also looking at why it is that as you fall in the socioeconomic ladder, you also have higher chronic diseases. It seems to be this link between chronic stress. It's interesting because we tend to look at what are the leading causes of morbidity and mortality, cardiovascular disease, stroke, and then you look at what causes those, smoking, driving without seat belts. But then this is, well, what causes those behaviors, so that you have a fuller picture and where the intervention has to take place. This is just one example of what are the social forces underlying ill health. And you could probably make a bigger impact on the health of our country by getting more kids to graduate from school than we do with a lot of our medical interventions. Just the fact that they have higher incomes, they're more in control of their life. As you increase graduation rate, health risks go way down. Less teen pregnancy, less of everything. There was this, you remember Jonathan Mann in New Mexico? He was the head of epidemiology in the state. He became the head of global AIDS in the WHO. He worked there for about 5 or 6 years before he came back to the States. And his conclusion after working with AIDS for that many years is that if he were to make one intervention that would have a bigger impact on reducing AIDS, it really wouldn't be the vaccines, it would be increasing the rate of girls graduating from school. That was the intervention that he felt would make a much bigger impact, where they had enough choices, income, that independence. So this is powerful. There's data here in the United States. This came from Robert Wood Johnson. And it's very interesting. They have indicators, and you can do this for Kentucky. Every single state, you can say, where does the state fit on, in this case, it's any college or post-high school education. And we just did it for next. So suppose instead of, I don't know, 56%, suppose we were 80%, we would decrease 677 deaths per year in New Mexico. I mean, you're now getting data that will tell you what that intervention may actually do. So if you take a look at this, for example, what are the ways? We're not trained in elementary school education. On the other hand, if you look at the big employers in the future, in New Mexico, every employment is going down except health. It's still going up, right? This is going to be, we're all getting older. This is going to be the big employer. So if we can get kids excited about health careers, they will likely have jobs and in needed areas. So we have mobilized our different colleges at the Health Science Center. We have associate vice presidents for Hispanic, Native American, African American health. They're all having some component of their work working in local schools to try to get kids to stay in school, get excited about health careers. We also have a BA-MD program, meaning we have currently 75 students. This summer we go to 100. That extra 25 are all coming out of high schools that have been pre-selected, and they're now finishing their 4th year of college to enter medical school. That group, that extra 25, to move from 75 to 100, 2/3 are ethnic minority and rural. The demographic of that group is very important in terms of where they're going to practice in the future, how they're going to ameliorate a lot of those things I said before. Those kids are all working in their local elementary, high schools, back in their home communities, because they're all from rural or underserved New Mexico. We've changed our admissions policy for the medical school so that we have kind of packed it with primary care ethnic minority faculty and people from the community, because we know that admissions committees clone themselves. They get excited about people who look like them. So we just changed the nature of the. Well, for the first time, we now have 9 Native American students just admitted to the medical school. They're all given a free ride. It's very hard for us to recruit because they're given free rides at Stanford, Dartmouth, and Harvard. But by giving them free rides there, we have the added advantage of a peer group, and they're all able to go back to their tribes multiple times during their education. I'm going to describe the certificate, public health, and then the residency, which we are now decentralizing into rural communities. This is for you. What we decided is every single doctor who graduates has to have a public health perspective, regardless of what specialty they're in. If we're going to have an impact on community health, we now know from the data I just showed you, it's not good enough to be absolutely fantastic doctor sitting in a clinic or sitting in a hospital. You have to be able to look at what are the community, population, public health dimensions of anything you do, because there's not enough of us if we're just going to be sitting in clinics. So we're the first medical school to do this. Every medical student will graduate with a certificate of public health. Now, we came up with this, and I had in the Vegas idea what it was, but I looked at it, what it is, 1/3 of an MPH. And Our goal is not that everyone gets MPHs. If they want to go ahead, that's fine, because all of these are transferable to MPH programs. But our goal was, can you orient them in a different way? We didn't want to sequester it as a separate little anything. I mean, we have plenty of people who get MPHs concurrently, or they take an extra year. We want everyone to get this. So we've infiltrated all parts of the, these are 4 years, all parts of the curriculum, getting these various skills, but in a way that it's usable. We've taken the residency and decentralized it. Now, this is the largest residency in Albuquerque, and then we set up 3 sites, Las Cruces for the border areas, Eastern Plains out of Roswell, and then northern New Mexico and Santa Fe. Now we're going to start planning for one in Farmington in the Four Corners area, Silver City in the southwest border area as well. What the data shows is, and has to do with access, that about 30 to 50% of the graduates from the Albuquerque program are working in rural New Mexico where the need is greatest. 80% of the graduates of the 1+2 rural programs are currently working in rural New Mexico. So where you train, the connections you make as a resident are very, very important. It's not easy to recruit, it's hard to sustain, but the data is so compelling, we're now working on strengthening those programs as an access issue. Now what about research? If you look on the right, these are the signature. This is the major, this is the pride, the leadership in research. These are the areas that we focus on. Cancer, cardiovascular, metabolic disease, brain and behavior, infectious disease. Oh, they happen to fit the NIH funding. We're driven by the resource. Every county in New Mexico has a health planning council that's broadly representative of the different sectors of that community. Law, business, health, policymakers, legislators, it's got everything on. They're really quite something. Each of them comes up with a plan every year that's their priority. This list is simply taking all 33 counties, melding them together, and this is the rank order. Substance abuse, obesity and diabetes, teen pregnancy, access to care, and violence. Now, you can try to stretch some of this, but this is not driven by that. So now what we're doing, and we're helped by the CTSC planning, is connecting the two of them. There has to be a way, again, that the academic health center and its resource can respond to the community priorities, not just our own. There are several service innovations we've done to try to change the nature of care responsive to community needs. The first is about 40% of the patients that we see at University of New Mexico are uninsured. And it's a very high number, maybe about a third of that are undocumented immigrants. But what we did is we got the hospital convinced that if we could just take the uninsured and give them a medical home, sliding scale, and reduce cost for medications, tests, and hospitalizations, we could see if we could give better quality care and reduce the cost. And lo and behold, it happened. We started with the first of 7,000, and now it's 30,000. But basically what it's done is it's sharply decreased ER visits and hospitalizations. It's a real cost saving. So that we can just do things slightly different. This is not a huge expense. It's changing. They even took the social workers out of the hospital, a lot of them, out of the hospital, put them in the clinics. Ah, terrific. It's a better place to do prevention. What we found is there were still people who were not connected to medical homes. So we have a mechanism now in the emergency room. If someone doesn't have a medical home, click, 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 we have a computer program. We assign them the next day to a medical home. Here's the doctor you're going to see. Here the, a sheet is printed out. And then we found the number of social and economic problems besetting people who are uninsured are so high that we've begun to develop essentially community health workers doing field case management. The reason is a lot of patients who are in need never come to the hospital. They don't come to appointments for case management. They're just disconnected. But what's important is if you go out to them, you could begin to give services. So instead of waiting for people in an office, we send folks out and do basic management in the community, and that has made a huge difference with a big decrease in use of emergency rooms. So that has been a model. A lot of people are using telehealth, and I think you have that here as well. There are 3 kinds of telehealth we use, and we're now trying to link them all. The first is, I'm going to go from bottom up, is we've got, I think we're the only state that does this, we have a 24-hour nurse advice line that's kind of shared funding with public and private funds. Anyone in the state can call this number 24/7. If you think of what's happening in our society, the nuclear families are getting smaller and smaller. Many people with sick kids don't have a grandmother to tell them what to do anymore. They're just frightened, and they're home. About half the calls to this line are kids. I mean, for kids, half for adults with all kinds of problems, mental health, everything. And what this has shown is a sharp reduction in use of emergency rooms. So it's now a line that's being funded. It's probably the best public health intervention we've made recently, that line. So you can have something right to the home. The next is the more traditional telehealth, which goes right to the doctor's office or the emergency room when a patient with, let's say, a stroke or whatever the critical area is. Many areas they don't have any dermatologists. We're trying to get telederm at certain places. We're even using it for pharmacies. If you look in rural New Mexico, if you lose a pharmacist, you've lost a big business in that community. But there are farm techs all over these rural communities. The regulations are, unless you have a pharmacist on site, you can't dispense. So we've gotten the pharmacy board to agree to allow us to have a remote pharmacist using telehealth look at the patient, look at the prescription, and then the farm tech can dispense, saving businesses all over the state. And the last is Project ECHO. It's a wonderful model where you can have university-based specialists on Polycom, and they can connect with primary care providers in different areas of the state. And the purpose here is to train them in how to manage complex chronic diseases, hepatitis C, complex diabetes, whatever they may be. And they have a little schedule so that you can go online and you can learn. And usually they'll have 5 or 10 different practices dialing in so they can present their cases and learn at the same time. So you have these different layers, and they've all started from different sources. We're trying to put them together for the needs of communities. Now, in working with communities, these are absolutely true. It is not easy, and health science centers have a terrible reputation among many communities. Most university community partnerships are one-sided altruism. The university gives things to a needy community, compensated by warm feelings and a grant until it ends. And this is why we're told constantly, yeah, you come with a grant and you're going with it. There's no commitment to long-term relationships. Well, we set up our office several years ago, and the genesis is interesting. It was our new executive vice president, who was also the dean of the medical school. He kept both jobs. Why? Because the money's in the medical school. He didn't want to lose that. And he went to the legislature with his list of requests that had been given to him by the different colleges. And he got negative feedback from the rural legislators. What have you done for us lately? All you ask for is more money for more buildings in Albuquerque. Nothing for us. So he was shocked, and he did several things. One of them was to create our office as a way of saying there has to be a way we can relate better to communities around the state. And we start to put together different aspects of our office that we thought would relate, you know, telehealth. I assigned these different associate vice presidents for different ethnic groups. We got communications, we got oral health. We have lots of things in the just trying to respond. And then we spent 6 months asking communities what they thought of us and how we could be a resource to them. And this is what they said about it. Most of it was positive. But these were the things that were troublesome. We are known as the University of Albuquerque. We only come when a grant comes. We always come with our agenda, never theirs. Now, they said they will never tell us no for fear we'll never come back. But it's never what they want. And then they said, why don't you commit to a long-term partnership, you know, and ask them for their leadership, their wisdom, their ideas, and build their programs. And then why don't we have more of a presence like New Mexico State? You don't compare very well to them. It's like telling Louisville, you know, Lexington has really got it over you guys. We're competitive. They're the land-grant university, and we're the flagship university. They're down in Las Cruces, we're up in Albuquerque. So, and we beat each other in basketball and football. I mean, this is not a pleasant relationship. So when they say we don't compare well to them, this is an insult there. So we had to figure out what they did, and these are some of the things we did. First, we said, okay, look, let's change our vision, let's change our mission, and this is the new vision, which is just approved by the leadership of the Health Science Center. Think of how competitive. Working with community partners, we will help New Mexico make more progress in health than any other state by 2020. Okay, now, we got the juices flowing. We've got to beat out everyone else, right? So it's appealing. But the operative word here is health. Because when you're talking about health, you're not talking about how many patients you see, you're not talking about how many grants you're not talking about fame and fortune. You've got to actually measure people's health. And we know now that 80% of that is not going to be what we normally do. It's going to be a lot of these social determinants. There were three major programs. I'm going to focus on one and mention the others that we are mobilizing to intervene. The Health Extension Program, which is the focus of this, academic hubs all around the state, building on what we've done with the residencies, and then a partnership with the Department of Health, which would be interesting. So, our nemesis. New Mexico State University has got it all over us. And the reason is that they have agricultural cooperative extension workers in every single county. Every state, by law, by I don't know what, since probably Lincoln's time, or certainly the turn of the century, has had to have a land-grant university. Those are always the Aggies, agriculture and mines. Those are set up specifically to help local farmers, local business, do better, using the science of the university and the college to the front lines. What a concept. And they do it through extension agents that are in every single county in the whole United States. Who knew? To me, it's like matter, antimatter. I never knew about this. And so we work absolutely in every single county, in every city, every neighborhood, side by side. We don't know each other. We don't talk to each other. Okay, so if that's the model, then we said, well, let's do the same thing. Why don't we create health extension agents, paralleling them? But I didn't know whether they've, co-opted this word. So I had to go and I met with the president of New Mexico State University. Wonderful guy, very self-assured. He just became the chancellor of Louisiana State University, LSU. They just won the championship. Anyway, he was a very, hail fellow, well-met kind of guy, backslapping guy, self-assured, so that he said, this is a great idea. Yeah, I like this idea. You create health extension, we've got cooperative extension, and together we'll be the big dogs in the state. We'll help communities by the forces and the strengths of our two universities. So that's what we've tried to do. Health extension agents. So what is a health extension? Well, first of all, we got ourselves a logo, right? A little rural mailbox, a little snake going up there, so it's kind of both. But they have to be full-time in communities, which is critical, because usually health science, remember, goes back and forth. We've got to stop that. We're in communities for the duration. We have to have an agent, identified somebody who's full-time there, never leaving. Okay. Their role is to link the community's health priorities with our resources, as well as tapping into New Mexico State's. And they've got to monitor what they're doing. So it's not just doing stuff. Are you showing you're improving health in any way? This is what it looks like. We don't have a lot of money, so we do it with volunteers, all of whom have other roles. But the power of accessing Health Science Center resources is so enormous, they do it gladly. They can't do enough of it, actually. So these are just, and we do much more in this, but these are just examples of the kinds of things that extension agents draw. These are their priorities. These are ones that we've addressed, all of them. The state is very big, though. It's the 5th largest state, so we have regional coordinators that help work with them, and we have one tribal coordinator who works just with tribal issues. And they go all the way from education, service, research. The university's interest is often around research. I would say that's the lowest priority for communities. It usually starts with, get us a doc. I don't have any dentists here. So you have to build some trust. You know, there's these Maslow hierarchies. They got to survive first before you get to the other things. Education is increasing. They want to get their kids educated. They want to do a lot of local education. One of their big issues is if they have to send their kids to Albuquerque for training, those kids never come back. They need distance education. They need local training in order to grow their own workforce. And they work with all their local systems. These are just some examples. In one county in Hidalgo, they have developed through this relationship telehealth in general, telepharmacy, as I just mentioned, case management that we talked about, that's all over the county now. They developed the model of how to integrate all their health services, public health, primary care, behavioral health, social services, all in their clinics. And now they're actually the first county, hopefully be a national model, that they're actually going to try to get funding to take all of the managed care organizations, Medicaid and Medicare, if they could pool the funding in this small county, that they want to be paid for outcomes. Not just outcomes from the clinic, but community health outcomes. So if they can pull this off, I don't know if they can do it, but that will be a stretch. But if they can pull this off, this will be a model. So we're talking to the feds about them. Education, I just mentioned to you, this is Farmington. They've got everyone whipped up to sit their own family medicine residency, and they've got terrific resources. This will be very successful. I think I mentioned that one. This is an interesting one. We are the second highest food insecure state. Absolutely invisible if you're sitting in a city. You don't know, what is this food insecure? Well, what it means is this. These circles are as follows. Each center of a circle is a supermarket. The little circle is 10 miles away. The big circle is 20 miles away. And if you are not within those circles, your likelihood of driving 30, 40, 50 miles to get food is very low. You tend to get your food as convenience stores, 7-Elevens, truck stops. All high calorie, high fat, high salt. And the obesity level and the diabetes rates are very, very high in these other areas. Unfortunately, reservations are a lot of this area up here. So one of the social determinants we're working on is, can we work with local community colleges and others to actually start setting up pantries to deliver food, but the pantries go beyond delivering food also is how do you get local agriculture to be responsive? Because if you don't get fresh produce, and right now because corn subsidy is so enormous, all the bad stuff is subsidized and cheap. All the good stuff, all the vegetables, the fresh produce is very expensive. So we're trying to get things locally grown. As it turns out, many of these areas don't have civic organizations, schools, churches that have been willing to step up and run a pantry. You have food banks that have trucks running all over the state, but they can't deliver directly. They can only deliver to a pantry that's willing to distribute locally. So what we've done is set up links that will provide health screening, health services, social services, along with food distribution if the community is willing to set up a pantry. And that's what we're doing all over the state. So it's another way in which the Health Science Center can link with others around a big social determinant to try to address issues of obesity, poor nutrition, and diabetes. Here's another county. Their issue down here, this is a lot of pump jacks. There's oil being pumped all over the place. It is the smelliest place. You go, you fly in there, and you're just overwhelmed with oil odor. It has enormous wealth, enormous poverty, all linked together. They can't find an easy way to attract doctors to work there, or nurses, or anyone else. So their request to us is, if we build free housing, will you send your health science students there? Yes, absolutely. I mean, that'll be really attractive. So they've just put in a local foundation, $340,000 to buy a suite of rooms by the hospital for 12 years. And now we're going to start sending our people, because we know if you go there, the communities attract them. And we'll be able to keep, whether they're nurses, physiotherapists, students, residents, whatever it may be. So that's another approach. Here's a community, they wanted to integrate everything. I can talk about that one. This is a typical kind of request. This is from the Navajo Reservation in Crown Point, in eastern Navajo. And what they wanted was to figure out a way to grow their own health workers, as I mentioned. So what we decided to do is, let's have a mentoring program. We'll show the kids how to work with science, get them excited. The idea is to stay in school. They have the highest dropout rate. Their graduation rate is in the low 40%. High 30, but depending on the community. So the first thing is get them excited, stay in school, but link them to mentors, both there and in Albuquerque, to see if we can get more of them to stay in. And we could train them in many of these fields on the Navajo Reservation by distance education. Another spin-off of this is realizing that in addition to having health extension agents, what about taking our health science center and decentralizing it? So we got our executive vice president to agree, yeah, here's going to be our mantra now that we have our new making more progress in health than any other state. Now will be, the state is our campus. You know, we're going to piss off every other academic center, but the state is our campus. So the state is our campus, and we are now working with community hospitals that they become academic hubs. Now this is not just words. I mean, that means they're getting more training, they're participating in research trials, they're doing a lot of the recruiting locally. So you can, and what we notice is local community hospitals invest a lot of money locally because they're going to get the outcome. As long as we can train nurses locally, they're going to fund it. So that's one of the, and now here's another little thing. With the current legislation, there's a big battle over it to see if we could have federally qualified health centers, community health centers, be teaching health centers. So there's big dollars in this legislation if we could ever get it past your senator and Lieberman. But that will be another step in decentralizing training. And we know if you decentralize training, look at our data, you can really get people to stay locally. And that will improve not just the health, but also economic development locally. Each doctor in a rural town hires about 18 people, directly and indirectly, generates $1 million of business. This is a big boon to small towns. And just the last few slides. The part of what we've done now is link with our Department of Health. We have an easier time of this because the new Secretary of Health in our state is one of our medical students and family medicine resident graduates, is one of our buddies, so we can do things quickly. And what we've decided to do is form this partnership for the reduction of health disparities, seeing if we can't link the resources that are out through public health and all their data sources with the resources from the Health Science Center like we talked about, and then begin to measure, can all of these interventions actually make a difference in health? And it's very strong when you have them as an ally. And what we decide to do is try to intervene, and we asked lots of people, in the areas of different people's comforts. Like some, you want to be able to say, what is the community priority? We may say it's too many, I don't know, infectious disease. But they may say, no, it's housing. And we know from experience that if we impose our priority, it never lasts when we leave. It has to be community driven. So our first question is, what does the community think its priorities are in different areas of the state? The second is there are geographical issues because there are legal entities, there are legislative entities, so we have to work. Then there could be information by ethnicity and then by chronic disease. And you can see chronic disease would be comfortable for academic health centers, because that's how we're structured. On the other hand, from communities, these are often much more salient. So we have to approach it in different ways. And this is what we did just in one county, Lee County. Here's the population. Gives you what its economic base is. And these were their priorities, housing and teen pregnancy. And we looked at some of these other risks that the health council set as a priority. We then are tracking every county, and there's like about 50 different items here, but we just took the ones that have high disparities in this county. Okay. There was a question that you had about how do you track. So this is a way of tracking. We compare it to the rest of New Mexico and then to U.S. set. So we can say, well, gee, let's see. Yeah, smoking is big, obesity, high school graduation is terrible in this county. And then we say, well, what's the health workforce here? So we have, this is what you would expect. That is, if you said per 10,000 population, you need this many nurses, doctors, and this is what they have. So there's a gap that we have to try to fill, not just our university, but all higher education in the state. We can't rely on importing anybody because every state's trying to import. So you have to make the presumption you got to grow your own. We are now working on separating this out to primary care and the different specialties. But we have to know as a health science center, how are we doing? Well, we're not doing that well. You know, we can't just say because we graduate, so where are they going? Are they serving in areas of need? And then there are data by different ethnic groups. So this will be, you can do exactly the same thing. You can look at what are the risks. It's higher in some categories for African Americans, others for Hispanics. There are no Native Americans in this county, so that's not an issue. Then we're looking at, suppose you looked at mortality. There's different ways of looking at it. Look at mortality rates, and then look at, in this case, for African Americans, because there's a whole section that works just with African American health. And lo and behold, in this area of Lee County, it not only has one of the higher percentages of African American population, it also has the highest, one of the highest mortalities. So then we go back and say, to this other data, what is the cause of that higher mortality? Is it diabetes? Is it alcoholism? And then we can zone in on that. And then we look at different categories of these risks I talked about. Remember, we talked about the health behaviors, care, socioeconomic factors, and you can rank every single county on these categories just as a snapshot. And here's Lee County. And it does not do well on health outcomes, a little better on determinants. This is a little risky. We put this out after the legislative session. I can tell you that Lincoln County loved this. They're up here. They're very excited. On the other hand, this group was angry at us. So we have to be a little careful how we use this data. It's really for us to start to look at what are the risks in each county. And then what we've done is said, let's put it all together. When we're working with communities or counties, we have a whole range of risks, that long 30 to 50 risks. It's almost like the Healthy People 2010. You can look at all of those, large numbers. What are the ones that the Health Council says are their priorities? Of those priorities, what are the evidence-based interventions that show that anything we do will make a difference? Because there's not that many. I mean, you're really shrinking down there for you. And then what is the role of the academic health center? A lot of our faculty are fearful that they're going to be judged on something they can't improve. They want to look good. So then we go down to, okay, of all of those evidence-based interventions that are approved by the Health Council and that are part of the list of disparity risks, these are the ones we're going to work on. And in this county, for example, these were the three areas: teen pregnancy, low graduation rate from school, and high asthma admissions. It's very interesting. They didn't know, is this high asthma admission because the air is just filled with this gasoline fumes? Was it because the housing is so poor as their priority? Everything is dilapidated and there's just dust all over the place? Or was it because of the access issues? The care is quite poor, the quality is suspect, and kids have especially high admissions. And guess what? Hospitalization for kids makes the hospital an awful lot of money. They're all covered by Medicaid. Which of those issues? So that's what they're currently trying to explore. It's a perfect example of how you use this intervention. The last thing, this is my last slide. The last is there's actual federal legislation that we wrote, and it's in this bill. And God willing, if your senator can only support this, just this one section.
Our senator is nicknamed Mr. No.
Okay. Except for this one second. Anyway, so this is called the Primary Care Health Extension. It was actually generated in Kennedy's Health, Education, Labor, and Pensions Committee, and it stayed in Harry Reid's combo. But basically what it does is it creates a national program where you would have in all states that apply and receive this, lots of agents all over helping not just practices, but also helping communities make these ties that we just talked about. Okay, so that's all I have. Thank you.
Thank you, Dr. Kaufman. We now have time for questions.
Could you talk more about the healthcare legislation that's going on healthcare nationally?
So the question is, can I talk more about the healthcare legislation nationally? No. Yeah. So I think there's a core that will pass. They're going to have to sacrifice a lot of the contentious issues. There's no question it's not going to be public option. There's not going to be buying into Medicare 55 on. They'll keep peeling away. I think they may. It's unclear whether they'll have to make abortion even more restrictive. But I think for the Democratic Party, it is so necessary to pass something that ultimately the liberals will have to compromise. And what we'll be left with is a lot of the legislation that has more to do with pre-existing conditions, access to many more people. A big concern, however, and some of the other things which would be good. The problem is I don't see the control on cost. And I think that's what's going to be. So I think the only way that this is going to work is something passes and then lots and lots of attempts in coming years to try to modify it. But the way we're structured now, it's going to be jammed. So I think there are lots of pieces I like. I'll tell you one of the big fights within medicine is this. If you look at GME, you're residents? Okay. Interns, okay. So if you look at what's happening now. If you look at data, look at the Dartmouth Atlas. What did it show, or any of the data coming out of Starfield's work? What you'll see is that if you could expand primary care, it is the only way we can make a substantial improvement, not just in access, but actually health indices, primary care. Our professional organization, AAMC, has come out, not for that. It wants to use this crisis to increase by 15,000 the number of GME slots with no strings attached. Well, who is going to expand? You're going to expand more and more of the residents in the subspecialties and the procedural specialties that make the hospital a lot of money, but don't help society, actually will decrease health. But this is their chance to expand in the way they want. So there's a disconnect between what society needs and what academic health centers are mostly asking for, which is a tragedy to me, at a time when we could really make an improvement in health.
So why is that?
Because people are looking at their self-interest. The whole way legislation works is self-interest. And it's a compromise between lots of people's self-interest to see can we make a compromise that helps everybody but doesn't step on too many toes. The current legislation steps on a lot of toes. If you look right now, the reward for keeping the system exactly where it is absolutely huge. The ability of paid lobbyists to influence legislators, to put money in the coffers of legislators is enormous. It's very hard to change that system.
I would just like to applaud you, for reintroducing the biopsychosocial model into population health. I grew up, with the model, Dr. Vonderhaar hired me, in 1976 or so into family medicine. And I've watched, with some sadness, of a decline in biopsychosocial model. And I'm glad that David has this program. But it seems that family medicine wants to be more like everybody else, and we try to be the mini pediatricians or the mini generalists, or it's ridiculous. And you brought back quality of relationships and logic and rationale and political fortitude, on a huge scale. And I just really think that what you're doing is sorely needed everywhere. And you as a family physician, being involved in social change is it's incredible. I'm really glad you're here. I'd just like to make one comment about Michael Marmot's model.
Yeah.
I teach that, in the School of Public Health, and I'm still studying it. It's difficult, but basically the model is to look at the resource base of a population, let's say in quintiles, so that you have a lot of wealthy people, well-educated people, and you have less wealthy, low-educated people, and the difference or the gap in the resources determines the social gradient, which translates into incidence and prevalence of different diseases. Now, I think what's happening is that with the financial change or economic change in the United States, my assessment is that the gap is actually increasing. And I would predict that what we will see is more socially enmeshed conditions, more alcoholism, more substance abuse, more violence. And what I heard in your presentation was that you're still being a good doc, and you come back to a disease intervention model, and I'm looking for better ideas about how to deal with a changing and worsening steepness of that social gradient, which is a community health or population level indicator. We can give all the insulin and diabetic exams that you want, but until that gradient, comes back to normal from the low end going up, I don't expect there to be much change.
So let me summarize at least the last part. The first part was you like to talk. The second part was related to Marmot's work and in social gradients. And if you look carefully at it, what it shows is all of these social forces that if we kept doing the same medical model wouldn't have much of an impact on that. So let me address that. Because if you look at the enormity of the money that goes into the, quote, curative system, it's like 97%. What goes into the preventive upstream system? About 3%. Now, in order to mobilize that 97%, and especially if you start with our allies in the community, they have an expectation that you're going to be a doc and you're going to be there. And that's that Maslow's hierarchy. We have looked around the state, and in order to have credibility, we actually respond to what their priority needs are. Often taking care of patients, there's a crisis, you have to deal with that, but there are other underlying preventive issues that you then have to get to. And that's why we're trying to blend both. It's not that it wouldn't be better to take this vast resource and work at the upstream level. It's that I don't think we'd be allowed to. So I think we have to use the fact that we do have a skill. It has benefit, but not as much benefit as if we could mobilize this other part. Now, the other part about Marmot's work, which I think is interesting, is he says that it's not just the income itself, it's the lack of control you have over your life that creates the high stress. And he's looked at communities that overall are poor, but the disparity is less between rich and poor. And I know that when I walk into my chairs meetings, and if our dean says, you know, Art, I like your stuff, I'm going to give you $1,000, but that guy next to you in emergency medicine, I'm going to give him $10,000. I'm miserable. I got more, but the disparity makes me furious, right? Or if he says, we're all going to take a hit for $10,000, that's tough, but we're going to. So I think I feel it personally, and I know that it must be horrendous in society. I think you're absolutely right.
Well, then it's hopeless.
No. Why is it not hopeless?
It's not hopeless because the future is not yet written. We have time for interventions. We have time to pay attention. We have concerned people who are paying attention and actually starting to look at where are our priorities mismatched, where can we change.
Right.
The priorities need to be based on resources. Right. And distribution of resources, like building, the new housing, in southeastern New Mexico. What a great idea. What does that have to do with health? Everything.
Yeah.
Exactly. So that's why, let me summarize again. So the issue is not one person says, so it's hopeless. The other person says, no, it's not, because the future isn't written. The other question is there are examples now of this other kind of intervention. And I think as long as we realize that as health providers, if we can hitch our wagon to these other stars, then we can really zoom. They are highly dependent on us. If you watch how successful we are at blocking needed wonderful things, we've got to change that. But if we could be advocates for these important changes, that means everything in communities. We don't have to lead everything, but our voice has to be there in a positive way.
I'll share one more idea that I tried to accomplish here. I failed, but I really think it's a really good idea.
Then I'll take it to New Mexico.
When I was acting director at the county health department, I tried to make a network of the board members sitting on other boards that had to do like with health.
Yeah.
Like put a Board of Health member on the Jefferson County School System Board of Health, or on the Energy Commission Board, or you can go on and on from there. You know, it makes perfect sense because those are the health resources.
Right.
You know, everyone on the Board of Health liked the silo, you know, and they didn't like the idea of going outside.
Okay, so this is a very important point, that this vision was very important to really decentralize your resource to sit on other boards so that there would be more like a real networking. It didn't work because people tended to want to revert to their own silo. Okay, now that is important, and if you look at the what has happened throughout New Mexico, this is why we're spending so much time in trying to link public health and medicine. It's wonderful on paper. It's very hard to do. And one of the reasons is the history of medicine and public health. They never should have been separated in the past. But what happened was, if you look at the history of this, medicine kind of grew in an entrepreneurial spirit. I mean, people had their own practices. There were small businesses. It didn't grow as a public good. It didn't grow, I mean, only for poor people it was public. And so we often approached the care of poverty, let public health take care of that. So okay, so then they built up their kind of poverty care infrastructure. Then Medicaid came along. Give us those patients back, they're paying. So public health was so jerked around that their trust is kind of low. So when we say, let's work together, all they hear is, you're going to take our jobs. So I think we have to be very careful understanding that history to get these two cultures together. It's desperately needed. And we have examples all over New Mexico in the same building, public health and primary care, and they don't talk to each other. They run to opposite ends of the building to have their own little turf. So we've actually created these health commons where you physically can't escape from each other. You have to live on top of each other. There's no place to go. They're right there. Because we have to overcome that history. You're absolutely right. Yes.
Comment on any role the health extension agents may play in response to swine flu.
Okay, so then the question was, could the health extension agents play a role in swine flu? Yes, and I'll give you a perfect example. The Central New Mexico coordinator for health extension for New Mexico, there are other extension agents, but this is the coordinator for the region, is based at the university. Well, what he came up with as an idea is, wait a minute, we've got like 20,000 students at the university. Why can't we mobilize them to go out to the schools and start to immunize everybody? So he got all the health science students, he got a program which you can go on the computer and you can sign up for whichever school. There's like 50 schools. And he got all these kids immunized using the volunteer services of the health science students. It fit in with our notion that every health science student should have a public health role. So it was educational for them. It helped the students. Now we're waiting for the H1N1 to come for the next round. So it's a very good example of using a resource. And remember, his role is to link community need with health science center resources. So this is a perfect example. Good question.
Any other questions?
You've been a wonderful audience.
One quite. So.
In the opposite direction. I mean, I guess U of L is going to add a few extra students here. I forgot the number, but the school's going to get bigger, but it seemed like as long as the residencies are mostly in Louisville and so forth, but that's where the kids are going to stay, and they're all going to plastic surgery and interventional radiology and...
Yeah, so the issue is, wait a minute, the trend, though we may be let's say for access, we may be increasing the number of doctors, they're not the doctors that are in the proportion we need. That's right, because the decision making is not at the community level. It's at the level of those who are self-interested in perpetuating the same ratio we currently have. It's just like the RBRVS system. How do you decide how much one is going to get paid for a procedure versus a specialty visit versus a primary care visit? It's made mostly by specialists who sit in a room in Washington, and that's how the decision. Well, guess what? They have decided that their income is going to be higher. It is totally a conflict of interest. That's one of the things that they're trying to change in legislation, but there's fierce fighting against it because whose ox is gored? We're not starting from what makes the community healthier. We're starting with which control we have, our self-interest, our silo, and that's what's happening now. You're absolutely right.
You know,
those trends are going...
I'm the last group that did a regular internship. And I remember at that time, because I had some special memories of that everybody in America at that time was saying we need more primary care. And what we did was, the next year or so, we said, let's get rid of the internship and everybody can go straight into medicine or whatever.
No. That's right. Well, that's why, yeah, the question...
People were saying they wanted primary.
Yeah.
And what we did is went exactly the opposite.
It's true.
That was what year? No, seriously. Seriously, what year was that?
I did my internship in 70.
So 72 is when family medicine officially became board certified. So that was the response. That's why.
Yeah.
Although the problem was we didn't have a large devotion of resources to go ahead and plow people into that.
Virtually every kid that went into an internship before 68 did medicine, surgery, blah, 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 blah,
That's
blah,
right.
blah, blah.
That's right.
And then from about 68 on, you started having straight medicine, straight surgery, straight this and that.
Well, one of the good things happening is if you look at the legislation, you'll see lots and lots of sections that have to do with primary care. People are beginning to realize this horrible disparity. Whether it goes through, we'll have to see, but you're seeing very strong push from most of the rural legislators to push this in, and that's why the bills actually are quite good. I mean, the sections of those bills are quite good. It's being fiercely opposed by people like senators from New York, because if you look at the amount of money they get for indirect and direct medical education, it is massive in New York City compared to what we get, for instance, in New Mexico, probably in Kentucky. They don't want to lose that gravy train. You've still been a wonderful audience.
All right, just one announcement on June